Welcome everyone to our seventh symposium for DHIS2. It's a real pleasure to have you all here. And my name is Busoy Anifalade. I am the Chief Implementation Officer at BAO Systems. And it gives me great pleasure to welcome you virtually this time. Hopefully it will be the last completely virtual, and next time I would be seeing you in person. In moments of crisis, we are often provided a rare opportunity to witness those who come into their own with chutzpah and rise to the challenge. The past 18 months have no doubt given the global community an ample dose of challenges. Our presenters for this session actually remind me of thrill seekers chasing the eye of the storm while others flee from it. But given that they're serious-minded, sober-sided individuals, perhaps you might think more of them as firefighters running into a burning house while others are running away from it. And so the phrase, "go big or go home," comes to mind as I introduce our illustrious presenters and speakers this afternoon, morning, evening, wherever you are. They have both specialized in deploying what is objectively and reasonably the most complex DHIS2 model, and are often doing so at a national scale. It warms my heart on this cold, rainy day in Cambridge to introduce Kwame Adu from the Ghana Health Service. He's the Health Information Manager and the lead tracker implementer for the government there. And Mike Frost, a senior advisor at the University of Oslo and the product manager for DHIS2 Tracker. Kwame and Mike are no strangers to pushing the boundaries of technological innovations in deploying scalable and sustainable DHIS2 Tracker programs. In this session, they will be sharing their experience implementing Tracker for immunization registries, vaccine certificates, perhaps also infamously known as COVID passports, perhaps, vaccine stock and logistics management. And they would be telling us lessons they have learned and how these lessons can provide valuable input for strengthening national immunization programs at large. So during the presentation, please feel free to use the Q&A feature to post your questions, and then we will take these right at the end of the session. So without further delay, I am pleased to welcome friends and colleagues. Please do join me in welcoming Kwame and Mike to present on DHIS2 for COVID-19 vaccine delivery.
Great. Thank you so much, Busoy. It's always nice to have you introduce us. It feels like we're actually doing something. So I'll go ahead and start sharing. So I'm going to go over a bit of what the overall general response has been around the COVID vaccine efforts using DHIS2. I'm presenting a lot of work of colleagues, of course, and people working in the countries and getting a lot done. And in fact, that's what I'd like the takeaway message to be from this session, is that what we really think has been the success of being able to support during the COVID-19 crisis, from surveillance to the vaccine programs, has been a marriage between a platform that was able to be flexible and responsive, but really truly local innovation and the hard efforts there. And hopefully you can see this through some of the examples we'll share. So just to get things started, I always think this is very important context. This is how we were able to quickly scale. The University of Oslo has been a WHO collaborating center since 2017, and the work that we have focused on has been to create specific configurations of DHIS2 that match global recommendations for clinical care, for indicators, guideline support, matching what data are expected to be both collected and reported on. And so we had, just prior to the COVID crisis, actually had expanded our team specifically to be able to create and support these metadata packages, which come additionally with the tools to install and the guidance documentation for different health areas. And so when the COVID-19 crisis started, we very quickly pivoted that same mechanism to create packages to support all of the initial efforts around contact tracing and testing and surveillance. And this, I put a bit of a timeline here so that you can see how this came about. So one of our early local innovations, again, was in Sri Lanka. The DHIS Sri Lanka team, 25th of January of 2020, very early, created a version of Tracker for port of entry screening. We then got just barely technical guidance published from WHO at the end of February. And in March, the 11th of March, I was actually with Kwame in Ghana. We were doing an academy there for Tracker when it became very clear that countries were shutting down and that everybody needed to return home for this very strong pandemic that was occurring. And while we were there in Ghana doing the academy, we had a couple of our packages team there that were frantically putting together a package based on this WHO guidance, which we were able to get out to the community within a couple of days, and hosted a hackathon where we had more local innovation coming in to try to support the various needs that the COVID crisis was going to bring. And by May of 2020, we had 27 different countries that were already using DHIS2 nationally for COVID surveillance. And that eventually built up to 41 countries. And again, I would say this is a very strong story of the platform and then the local innovation. We already had 45 countries using DHIS2 for immunization data. So they had the infrastructure, they already had the agreements with the Ministry of Health. They also had the tools inside DHIS2 that they needed for this. And they also understood the concept of the package, because we had 30 of those countries that had installed the World Health Organization EPI package. And so when we came to them with these COVID packages, there was very quick adoption and they were able to put them in place rapidly. So seeing the scale that we were able to achieve so quickly with the early COVID packages, we turned around halfway through the year last year and began working on the same thing for the vaccine response, which we hoped would be coming. So we took the NDVP guidance from WHO, which had these 6 components, and we created specific packages within DHIS2 to cover the EPI module, logistics, an immunization registry, health certificates, mass campaigns, and the reporting of adverse events. And you can see again that the adoption and scale of these has gone rapidly. We have at this point 35 different countries that are using DHIS2 for the COVID vaccine delivery. And what I'd like to do is go through some of the examples of the local innovation that has occurred while adopting these packages into their platform. So we have some 31 countries right now doing the immunization registry. For many of them, this is their first time expanding beyond aggregate DHIS2 and into Tracker. But for even more of them, they had adopted Tracker last year already for the COVID surveillance piece. And so they already had Android devices out, or they already had trained people on the use of data entry at the point of care, and were quickly able to pivot and begin collecting immunization registry data. This has also turned into a very important platform learning, because as these things went to scale, there was a massive uptake of Tracker beyond anything we had seen before. So the most recent numbers that I have coming from Rwanda were that they were up to 100,000 entries a day in Tracker as they pushed through their mass campaign. And so we at the University of Oslo were working very closely with various countries as they scaled these systems so that we could put in place performance improvements that then we were able to roll back into the core platform and make available to others. So just to take a quick look, this is Rwanda. One of the local innovations that they were able to incorporate was connecting to their national ID system. You can see a screenshot here how this works. When they put in the unique ID, they're able to pull the rest of the detailed information about the individual from the national ID system and verify that it's the right person, and also add that to their health records so that it shows that they've received the vaccination. Here's some local innovation from Laos, where they've been using the COVID vaccine registry as well, doing mass campaigns even in places like the shopping malls. They created a self-registration portal linked to DHIS2 that allowed a person to pre-register to receive the vaccine and then generate a QR code that they could bring in and scan and allow them to keep a record of their own vaccine history. And these are things that, again, we were able to get support from the type of platform that we have, being modular, being something that you can build applications on top of. We didn't have a ready-built self-registration portal, but with not too much effort, the Lao team quickly put one in place and was able to get it out there into the community in times for these vaccine registration campaigns. Of course, core analysis, data sets, aggregate data entry are a key part of the DHIS2 platform, the HMIS. We have at least 18 countries that are entering the vaccination efforts into the aggregate packages. Many of those are doing those in combination with Tracker for the first time. So they're learning the power of triangulating data between the individual data and the aggregate data. You have countries like Uganda, which are piloting the integration of all of their electronic disease surveillance with their EMIS data, their education MIS, which is a newer area for DHIS2 to be working in. So here's a quick shot of that in Uganda. They are kind of pioneering on the front of the education work, and the school systems are often being leveraged as points of vaccination centers. So it's a very nice connection. We have the adverse events following immunization reporting, which is, of course, vital when it comes to the introduction of new vaccines, being able to identify if there are patterns and specific negative reactions that are occurring due to the immunizations. 15 countries at this point using DHIS2 for reporting adverse events following immunization. And we had created a generic link to the global repository for this. So this takes it back to the platform kind of innovation, where we had a connection through the WHO to VigiBase, which is the global repository for adverse events, and have worked with them to create a link between the adverse events following immunization tracker and VigiBase. But then we've worked a step further closely with Mozambique and Mauritius to try to finalize that connection and make it something that's easily reusable for all the other countries that are using DHIS2 for reporting AEFI. 14 countries have been using the vaccine stock management approach within DHIS2. Again, from the platform perspective, we had gotten there just in time to have already introduced barcode scanning and to be able to link product catalogs with pictures. So it was not terribly difficult to configure this as a package that could specifically support the vaccine approach. We've been continuing to work on the kinds of analytics that this can produce and wanting these to feed into larger scale LMIS so that you can triangulate the health services data, the cold chain data, the logistics data. Sri Lanka is a strong example here of using the DHIS2 aggregated data to look at the stock received, issued, utilized at the various levels in the system. And so, again, learning from the Sri Lanka example and bringing what they learn and what their needs are back into the core platform. Vaccine certificates have been a hot topic. We've had multiple efforts about trying to introduce a generic approach to vaccine certificates. As some of you know, it's taken quite a while first to get the interim guidance out of the World Health Organization about what to do. It's been slow to build kind of a global consensus on this topic. The EU put forward their own standard. The US has a different standard. But what we've ended up doing is supporting countries that have decided to build their own approach to vaccine certificates. Some of those early efforts came through the DHIS Vietnam team piloting in Vanuatu and then also working with Laos. The Sri Lanka team, who worked with one of the more global efforts around DIVOC. Uganda, Rwanda, Tanzania, and East Timor all creating their own. You can see just a bit of the schematics here coming from the Uganda example, where the QR code is presented in the vaccination certificate at port of entry or at travel. They can have that QR code scanned. It will bring up the information that's pulling it out of the citizens portal, which is getting the information from DHIS2. So again, all of these efforts, I think, were the quickest and most successful efforts happen directly by the countries themselves and the HIS groups working with them to create these certificates. And now that there has been more of a movement around the EU standards for certification, they've actually been able to go back to several of these countries and get them into the accepted EU schema for certification. So we'll continue to learn from this and see where it goes and whether this turns into a generic approach to certificates. But in the meantime, every country has the opportunity to do something similar. We often get some pushback about whether this is really the right thing to be doing at this point in time. It's a global pandemic. Many countries have fragile systems. They don't have the infrastructure. So we just wanted to show that some of even the most challenging environments in which we work have also moved forward very quickly with being able to deploy DHIS2 for COVID vaccines. Chad is putting forward their first national scale DHIS2 deployment. They're working with the vaccine module, the immunization registry, adverse events stock. So they're moving forward very quickly. Central African Republic with the support of HISP Western Central Africa. So quite a lot is going on, even in the kind of more challenging environments in which to work. We found that despite the concerns, actually the uptake in the rapid use of individual data collection has been really powerful. This is really what we're getting at when it comes to being able to do a 2-dose vaccine and be able to provide proof of vaccination, is that you really do need this longitudinal record and you need to have the individual data. This needs to be linked to national ID systems. And so we've seen country after country be able to do this and link these data points to a national ID schema. Maybe a less fragile country to mention, I heard Laura talking about this in the opening remarks. You can see this screenshot here is from the largest newspaper in Norway, talking about I know we don't all read Norwegian, but you hopefully can recognize Uganda and Sri Lanka in the headline there. The newspaper talking about the lessons learned from these other countries, which have now come back to Norway for their first use of DHIS2 as part of their health information system. And it's become something that is, again, available in about half of the various administrative units in Norway and has been running now since the beginning in terms of the COVID surveillance and contact tracing, and now continuing with vaccinations. So from, again, my perspective, all of this is a great vindication, I think, of the strategy to create a robust and flexible platform that can be owned by the country and can be worked with the government, that they can use local innovators and local IT support to be able to adapt and adopt the solutions and expand upon the services that they already offer. And that we at the University of Oslo also are very lucky to be able to learn from them and bring those improvements back into the platform. So anybody that's newly upgrading their tracker system or planning to expand the use of tracker in the coming years, you have Rwanda to thank for that. You have Ghana to thank for that. You have Sri Lanka to thank for that, because they were the ones that expanded the use of tracker so rapidly that we were able to learn quite a bit more about how to improve performance out of that system. So with that, what I'd love to do actually is now turn it over to Kwame to talk to us specifically about a country who's done a lot and done a lot on their own, the Ghana Health Services. So Kwame, I will stop sharing my screen and I'll let you take over.
Yes. So Mike, please share from your end. I was having a bit of challenge.
Sure, just one second.
Great. So thank you very much, and thanks for having me. So I'm Kwame, and I'm going to share our experience in Ghana. I think Mike mentioned earlier when at a point the whole team was in Ghana, and they had to how do I put it? They had to be evacuated because we had registered our first 2 cases in Ghana. So and whilst they were here, we worked with them to start something. I mean, start getting the models together. We only at this point used a immunization model, and then the AEFI models. So next, please. Let's go into the, I think we can skip to the outline. Yes. So Ghana was the first country in Africa to benefit from the COVAX initiative. So we received about 600,000 doses of Covishield AstraZeneca. And then we started deployment on the 2nd of March, 2021. Prior to we deploying the COVID vaccine, there were a few things we did. Next, please. I think in order not to waste time, I'll skip this to, can we move on to the next slide? Sorry. Okay, so we adopted the metadata packages to deploy DHIS vaccine delivery system in a matter of days. I mean, when we were ready, we only had to get the packages and quickly put them together and deploy them. So this allowed us to actually deploy DHIS for the first phase of our immunization campaign in some identified areas where the caseload was a bit high. So these were in the Greater Accra, Greater Kumasi, and then the central regions. So we deployed the case-based immunization registry as well as the adverse events following immunization models. And we use a system to register and deploy vaccines to close to 600,000 individuals. They made up the persons vaccinated for the first round because we only had 600,000 doses at the time. Next, please. Next slide, please. Great. So this is a roadmap. Sometime in November 2020, an application was introduced to us. We piloted it in one district for COVID vaccination. And as I go on, I will explain why. But when we were ready, when we had vaccines and we were ready to deploy, we didn't get enough support from the application. So we quickly had to adopt DHIS for our initial first round vaccination. And as I mentioned in the previous slide, we had to vaccinate close to 600,000 individuals. And we did that with a DHIS application. Now, after the first round, when vaccines, we had more vaccines. Can you please, yes, we had more vaccines. We were made to switch to another application. So we had to try to integrate the DHIS with that application because we were told that that application was going to take over. So we handed even data we had captured with the DHIS to the team, and they took over. But they were met with some challenges. So sometime in May, we had to revert to DHIS. So we have had quite an interesting story. We started with an Oracle system, and then we went to DHIS. We went back into an Oracle-based system, and then we go back to DHIS. So we have had quite an experience. Can we proceed, please? Next slide. Yeah, so the system is deployed across the entire country. Currently, as we speak, we have DHIS managing our COVID vaccination across the country. We currently also have in-house capacity. So we're able to manage most of the things in the system. For those of you who are quite familiar with DHIS, know that it gives almost real-time analytics. What we did was that we were able to set the system to provide hourly updates on the status of the vaccination. Next slide, please. Now, there were a few challenges. Inadequate tablets for offline data capture. Of course, because of the issues with internet connectivity, the best approach for us was to deploy the offline version, but then we didn't have enough tablets to deploy to the close to 5,000 to I think about 6,000 health facilities. So that was quite a bit of a challenge. And then inadequate capacity building, because we were moving from one application to the other, we didn't have enough time to do trainings and enough capacity building at the user level. So that also became a challenge. We had to do some emergency trainings. We had to run some sessions on Zoom. We had people who could not connect into the trainings because they were challenged. So these were some of the issues. Of course, internet connectivity is an issue. And then we had competing applications. As you saw in our roadmap, we had to move from one application to the other. And it's quite interesting because sometimes you are not too sure whether these applications are coming in to help or they are just seizing the opportunity to also do business. So I think this scenario is common in most African countries as well, where once there is a challenge, you have a lot of people moving with different interests. So we have also had our fair share, in this deployment. And then we had a few issues at our end. We had some downtimes and a few system issues. Some was as a result of limited resources, and we are taking steps to manage them. So here in the case of the inadequate tablets, we had to rely on partners to support. Thankfully, we've had some very significant support from the WHO, USAID, and other partners. They've come to our aid and provided a good number of tablets. We are also taking steps to have some top-up trainings in person, so we can build the capacity of the users. We encourage a lot more people to use the offline application because of the obvious challenges with internet connectivity. And then currently, we want to learn from other countries, especially in the area of the vaccine certificates. I think it's as Mike mentioned earlier, it's a big issue. And then we are currently verifying. There's an application which we are currently using to verify, but we are looking at improving and making things much more easier for ourselves. And then we are still engaging partners and stakeholders for resources, especially server and all that. So can we move on to the next slide, please? So in conclusion, I will say this. Some few lessons we have learned. We realize that deploying electronic systems does not guarantee automatic improvement in health, the quality of the data. And then you always need the human beings running the system to aspire for excellence to improve the data. I mean, the systems by themselves to some extent can support in improving data quality, but you still need people to make a conscious effort to ensure that the data they input into the system is of good quality. And then the quality of data from any information system, be it paper or electronic, has more to do with the attitude of people running the system and less to do with the system. The quality of data from any system is as good as the interest of leadership in its use for decision making. Thank you very much.
Yeah, thank you, Kwame, and thank you, Mike. That was actually such a positive message to hear out, almost from the fires of the COVID pandemic comes this phoenix of hope that you bring with your deployment. Well, lest we get into the realm of human hubris and saying there's nothing we cannot meet, let's go on to some of the questions. And I have a few for you guys, because the way you describe this, and I like it because you anchor your presentation within sort of the Ministry of Health context, and then where we know the usual challenges of capacity, resources, human skill sets, and things like that. And you talk about for all intents and purposes, a successful deployment in a rather very complex and challenging context, right? So my question to both of you is, you talk about the robust platform as well as local innovation being sort of the catalyst for this success. But historically, what bill brings all these countries together historically that allowed them to be able to leverage what they had to be successful with the deployment? Because it doesn't feel like this can be replicated just anywhere at just any time. So can you tell us what some of those components are that you maybe didn't touch on around the makeup of these countries?
Sure. And I hope that Kwame comes back. It looks like we may have just lost him. But I would say that this, for us, as we approached, well, let me say this. After the Ebola outbreak in West Africa, I think we actually did a lot of soul searching about what was the appropriate response to that crisis, because it felt like there was a lot of scrambling going on, a lot of, last minute quick fixes, innovative things that didn't end up contributing to the solution, but rather they kind of muddied the waters. And there was a review that the Norwegian Institute of Public Health did on behalf of the WHO, which said very clearly that during a crisis is not the time to be trying out new things. It's the time to be, building on infrastructure. And I think we took that very seriously, and have had that as a central point of our ethos for quite some time, which is that we want long-term relationships with the governments, the ministries of health. We want to build capacity over time. We want them to own and be able to have local IT partners, people that they can work with. And so that when these kind of challenges come along, they are able to more quickly pivot and respond to it. So that's, from a global perspective, something that we thought we were trying to do. And I feel like it's been borne out by the response here. But Kwame, I'd love to hear from you. Why is it that your Ghana team is able to be so responsive to this? And why were you ready already to deal with a tracker deployment, for example?
Thank you very much. Okay, so I think even prior to the Tracker Academy, had thought of putting some packages together to support in both the case surveillance as well as whatever was going to come up later. So we had thought of it. We had drawn some architecture and we're trying to prepare ourselves. So the academy actually came in handy. And then fortunately, the team was present here in Ghana. And then I think we had Marcus and everybody around. So quickly, that plan materialized. So for us, it was a breakthrough, let me put it that way. So we were fortunate, even though we had earlier tried to put a few things together. I think the academy in Ghana also crowned our efforts. So I think by the end of March, we had set up more like an end-to-end system in Ghana. Incidentally, we couldn't use it for some reasons, which I might not be able to go into details here, but we couldn't use it and we had to adopt another application to do the case management. But then when the opportunity presented itself for us to do the vaccination, we decided to seize it and then advance, DHIS and let the people know how the DHIS can help in emergencies. Because the story behind the vaccination, we were expecting a system, and about a week to vaccination, the system was not ready. So we had to quickly put together our DHIS. We did not have the comfort of even doing a large-scale training. We did most of the initial trainings on Zoom. And the challenges with Zoom, in a system like ours, where people find it difficult connecting into, the sessions and all that. So even with all those challenges, we're still able to deploy. And it was massive because we're able to register and deploy vaccines to almost, I think, 530,000 out of the 600,000 doses we initially had. And this happened in 6 days. And we were able to do that with DHI. So it was quite a success, if I may put it that way. But yeah, I think certain things are a bit political, and we all understand how things work. So
yeah,
how come we have to flip in and out of DHIS, from time to time? But
yeah,
we are here.
It sounds like blood, tears, and sweat, but actually maybe more positively, preparation, opportunity, and a big dose of serendipity kind of helped you with the deployment. So that's great. We have some questions from other people. I also have a few that I have here, but I'll take one. This person, they're currently working in Vanuatu, and they want a little bit more of an elaboration on piloting COVID vaccine certificates and what your experience has been on that.
Sure. So the certificate itself is not very complicated, right? You need to know the individual, their date of birth, which vaccine they've received, have they received 2 of them. It's fairly basic information. And so if you're using one of the solutions for collecting that data, you already have the data that's required for the certificate. At that point, then it's more of a question about how to handle the schema, for example, generating a barcode or a QR code, and what kind of verification method might there be on the other end of that. If you're going to generate something with a QR code, who's going to read that, and what are they going to see when they scan that? And so for the various countries, again, there have been local decisions made about how they want to represent this certificate and what should be that connection between the health information data and this verification process. There are kind of emerging standards about how to represent that for this kind of more of a global certificate. So one of the ones that, again, we've more recently worked with is around the EU recommendations, and we've seen those start to be adopted by a couple of the countries that we support. Maybe those are going to end up being more of the consensus than others. I'm not sure. But the ones that would be able to specifically speak with Vanuatu would be our colleagues that are working from the HIS Vietnam, HIS Sri Lanka offices. They've already done some support in Vanuatu for other purposes. So happy to put you in connection with them. Oh, Basoya, you're muted still.
Right. Yeah. So that's great. We're getting quite a few questions around, was this Ghana's first time using DHIS2? Was it Ghana's first time using the Capture app? And I think people are slightly just stupefied by, how did you do it so quickly when people take years? So maybe some historical context along, how many years has Ghana been using DHIS2, and how many years have you been using sort of the tracker Capture app application, and at what scale have you been doing this? Might be good to paint a good picture.
Okay, great. So Ghana has been using DHIS2 actively since 2012. We have been, for all those years, we're only using the aggregated, models. And then we adopted fully the tracker models in 2018. So currently, the aggregated model is actually our data repository, the national data repository. It connects all health facilities in Ghana. This includes private facilities, quasi-government, and then faith-based, facilities as well. So we have close to 9,000 plus facilities running on DHIS, and these facilities send reports on monthly basis. And a few reports are also reported on weekly basis. So DHIS is actually our national data repository for the health services. Now, the tracker has been deployed for HIV, TB, and then also maternal and child health. For HIV, it's been deployed nationwide. So we have that experience. And then also TB has also been deployed nationwide. Maternal and child health has been deployed in 4 regions. So we are doing some progressive, scale up, again, because of resources. The reason why we're able to deploy TB and HIV nationwide quite easily was that they have designated sites. So it's not every health facility which is designated an HIV site or a TB site. So even though we have close to 9,000 facilities, we have less than 1,000 facilities designated as HIV sites. So the number, even though it's across the country, we don't have so many facilities compared to, the other services. So it was quite easy to deploy, in these areas. And then the maternal and child health is quite extensive because almost every health facility provides maternal and child health services in Ghana. So we need a lot more resources to be able to do a nationwide deployment. So what we are doing is that we are doing some progressive, deployment. So as and when we get resources, we target a region and then we move in. So we are hoping to cover the whole country, but it's going to take us some time in the case of maternal and child health.
And
so
we've now got a deluge of questions in, so we might have to be rapid fire responses. The next set of questions, I think they want you to dwell on the preparation. What is the groundwork specific for pandemic responsiveness? What would you say would be the important, maybe, top 2, top 3 suggestions for how you can be ready for hopefully not a next time if this happens again? What should you be doing ahead of time?
So what has always gone to our advantage is capacity. I think it's good for countries to have in-house capacity. Yes, UIO has done a great job, but in an event of an emergency, because UIO looks at things at a global scale. But then if you have local capacity, you can even start something and then you can get UIO to come in to provide, or to help you polish it. So capacity is key. And then you also have to, it's difficult because resources, it's difficult to predict some of these pandemics. So there is no way you can be prepared. But what I can say is that now that most of the solutions are being digitized, it is always good to go in for solutions or for devices which can be used for other things as well. You shouldn't go in for devices which are limited, but you go in for devices which are as generic as possible so that in an event of any emergency, you can quickly put them to use. Because in our case, we deployed some devices some years ago, and we are still using those devices. They were some of the devices we are still using, for this COVID vaccination deployment. So first, you need capacity. You need to, when you are procuring devices, don't think of just today, but look at 5 years, ahead, and see if these devices can still be fit for purpose in the next 5 years or even more. So in our procurements too, we should be quite strategic so that whenever we find ourselves in emergencies, we can always fall on these devices. And then capacity. People need to appreciate that we are moving into a digitized, era, or we are in. But in our part of the world, we are still transitioning. But that is it. We need to psych people up. And that is one thing which we fail to do, because you realize that when you introduce digital systems, it takes a very long time for people to buy into it. So I think we need to psych our colleagues who are on the ground up so that they will be ready. COVID has taught us a lot of lessons. So I think from now onwards, we need to psych everybody up and look, when the time comes, we'll need to use tablets. You cannot tell us you are not proficient in using tablets. When the time comes, we need to get people to appreciate that. And I think that
is great. There are a few more questions, but I think I can squeeze 1 or 2 in, but you have to be really quick, like 30 seconds. This is around vaccine passports.
Yes.
One, is this integrated already with sort of the ministry or any other sort of government institutions? And then kind of very similar as well, what are the lessons that you've learned in enabling access to individuals who want to carry their own sort of passports with them, like their own certificates? So So something around the passports, yeah.
Yes, so in Ghana, we have the digitized and then also the card. So when you get vaccinated, you get a card, and on the card, you have all the details in there. And then those details are also on the electronic platform. There is a QR code. Once you scan, you can verify on the official Ministry of Health site. So that is how we are currently running it. We are working to improve it, but currently what we have is that we are using both. So in country, you can move around with the card. If you are leaving Ghana and moving into another domain, then they can quickly scan the QR and have the verification, just to confirm that the individual bearing the card has received,
And there still isn't a global repository for this, and there may never be, actually. But we have seen that the reason that I've seen now 3 different countries adopt the EU approach was so that they could be accepted for travel through the EU in that schema. So again, that may be something worth considering for your country.
Yes.
Yeah, and I know there is a question here about the rationale behind transitioning from a proprietary system to DHIS2 and back, and why the government did that. But I do want you to be able to walk freely in Ghana, so I would exclude exempt you from answering that question. Let's just say there are rationalities we probably do not have a handle over.
I will say that Ghana is not the only country that had that experience at this time. And just to say that, again, it feels like investing in what the infrastructure already was and strengthening that is just a key to success. Trying to bring in something new, no matter how fancy it looks, is not the way to go.
I think what I'll add quickly in just a second is this. You see, most of these proprietary applications were built outside the health system, because these were built by people who were not in the regular health system. So some of the things which are required were missing. So that is one challenge. So you realize that, yes, it is not that the systems are not good, but they are not fit for purpose. I think that is what it is.
Yeah.
But we are in the health system, and it's very easy for us to know what needs to be captured and how it needs to be captured. So that is how we went about it.
Well, Kwame and Mike, I want to thank you so very much for painting such a positive slant on what would have been perhaps many weeks of sleepless nights trying to get this thing to be done, and for such an engaging presentation. Thank you very much.